About some wound dressing, I have no conflict of interest. As I said, we have hundreds of wound dressing and young physician, young surgeon trying to choose the best one for management of diabetic foot ulcers. So we have something to explain and to orientate these young people. As a history, we remember the wound dressing began in the early 15th century, as you can see, with some linters, papers, cut and goes. And then after that, in the 20th century, we have a new modality of wound dressing. And the new century, 21st century, we have sensorial monitors, we have medicated polymers, chemical sensors, and so on. It's important to know that the treatment of diabetic foot ulcer and diabetic foot in general, it is a multidisciplinary approach. It is not only a treatment of ulcer, it is not only a treatment of wound. So we have to treat the infection, we have to revascularize, we have to offload the pressure of the bottom of the foot, and finally we should take care of the wound and use the wound dressing. For that, we have some important facts. Wound dressing are not a treatment of diabetic foot ulcers, never replace the correct and appropriate approach of diabetic foot. They, together with the adequate treatment of diabetic foot, will help healing of the wounds of these patients. And there is not enough evidence to support the use of any of these dressing, as we'll see at the end of this short conference. So as we know, in the chronic wounds, dermis is damaged or not exist because we have a lack of collagen, lack of fibroblasts, keratinocytes, and cytokines. What should be the ideal characteristic of a wound dressing? Should be sterile, easy to use, and cost-effective. Should provide a protective cover, maintain a moist wound healing environment, absorb the excess of the exudate, easy to change, non-adherent, non-toxic, and non-allergic. Also, does not contaminate the wound with foreign particles, protect the wound from microorganisms, allow gaseous exchange and control wound odor, provide thermal insulation and mechanical protection, and the most important, to be available in the area where you work. So for the dressing choice, we have a lot of factors that determine the use or the choice of specific wound dressing. Most important is the cause of diabetic foot, location and depth of this wound, amount of scar detachment, is this wound have high, low or moderate exudate, condition of a wound emergence, presence of infection and or pain, need of adhesions, and as we said, the dressing adaptability. How to select the adequate dressing? We have a most important criteria is the clinical judgment of the physician. Others, to keep wound bed continuously moist, keep surrounding skin protected and dry, control exudate, caregiver time, and cost-effective consideration. So for that, we have some primary consideration like moisture, drainage, control, minimized dead space, autolytical debridement, thermal protection, and external barrier. And for the advanced consideration of secondary consideration, we have enzymatic debridement, decrease in the bioburden, cellular stimulation, skin substitutes, and angiogenesis. Important to know before using wound dressing, 3 important questions. If we are able to answer this question, sure we will have the perfect choice for a wound dressing. Why to apply dressing is the first question. Second one, what to expect from this dressing? And the third question, how often they should be changed. So for the classification of wound dressing, we have 3 main classifications as a function. Passive wound dressing, protect action, or have a protective action, acute wounds. We use it in acute wounds, absorbable responsible amount of exudate, and guarantee good protection. For active, modifies the physiology of the wound, stimulate cellular activity and release the growth factor, used usually in chronic wounds, and maintain a humid environment that stimulate the healing process. For the interactive wound dressing, create a moist wound environment, interact with the wound bed component to further enhance wound healing, will reduce the colonization count, will reduce the level of exudate, will improve wound bed moisture retention, will improve wound collagen matrix, and will provide the protection from the epithelializing bed. So we'll begin with the most important types of wound dressing that we can find. The first group, hydrogels. They produce non-surgical debridement agents. They rehydrate wound bed, provide moisture control, promote autolytic debridement, and provide cooling for the lesion. We should use them in dry, low to moderate exudate wounds with combined presentation with silver as antimicrobial activity. Contraindicated, they use in highly exudated wound or where anaerobic infection is suspected and may cause maceration of the wound borders. We have many studies and many publications about hydrogel dressing, and this is one of the most important. This meta-analysis of 3 studies carrying hydrogel dressing with basic wound contract dressing found significantly greater healing with hydrogel. So it's important the use of this component. Second one is a calcium alginate dressing derived from seaweed, come in a form of calcium alginate or sometimes calcium sodium alginate or other times with alginic acid. Form a gel that absorbs exudate when in contact with wounds, help prevent scar formation and promote wound contraction, allows gas exchange necessary for a healthy wound bed. Also have a low adherence, reducing trauma at the time of dressing change. Conform to wound counters, low fiber shed, easy to remove. Calcium ions make the dressing take on a gel-like appearance and facilitate wound healing by providing a favorable microenvironment. So the action is the left side as to absorb a fluid, to promote analytic debridement, as we said. Here are the most important indication: moderate to high exudate wounds, special cavities, and with combination with silver will have antimicrobial activity. Precaution: don't use with dry or have very necrotic wounds. Use with caution on friable tissue, and don't pack cavity wounds tightly because that will reduce blood irrigation. Also, many publications about alginate dressing. The third group is hydrofiber containing carboxymethyl cellulose, an absorbative textile fiber bed, also available as ribbon for packing of deep wounds. This material is covered with a secondary dressing always. The hydrofiber combines with wound exudate to produce a hydrophilic gel. Hydrophil with Ag contains ionic silver that have a very strong effect as topical antimicrobial agent and to protect against many resistant bacteria. Absorb wound fluid and create a soft gel which maintain a moist wound environment, absorb and retain exudate and harmful component such as bacteria contained within exudate directly to its fiber. And as a result of that, will reduce or help to reduce the pain and the trauma upon dressing removal and conforms to the body or to the wound surface. Used in moderate to highly exudate chronic wounds. Also, many publications, and most important that conclusion we had standard care with appropriate offloading. The use of hydrofiber is so effective. We have some wound dressings that they use honey as topical antiseptic and antimicrobial. The history of honey use is for thousands of years. Its action rehydrate wound bed to promote autolytical debridement, antimicrobial action, and some topical nutrition. The indication is low to moderate exudate wounds, highly colonized wounds, and the precaution may cause drawing pain or as asthmatic effect and some non-sensitivity. Also, many studies and many published papers about the use of honey dressing. One of these publications is this one that I'm presenting, that the conclusion of this study is that suggests that honey dressing effectively promote healing in diabetic foot ulcer. The second or next group of wound dressing is nanocrystalline silver. Have antimicrobial action. It is indicated in critically colonized wound or clinical signs of infection, low to high exudate wounds, and with combination of foams or alginate will increase the effect. Precaution, some may cause discoloration, some types of sensitivity to this substance, and to discontinue after 2 weeks of no improvement and reevaluate the use of this nanocrystalline silver. Also, we have combination of both with honey, and the studies between both to know which is better. Nanocrystalline silver alginate was potentially superior to honey and conventional dressing in healing diabetic foot ulcer in terms of ulcer size and reduction of the rate time for healing. Some groups are formed by foams, absorb the fluid, moisture control, and it is conformability for wound bed. We use it to moderate to highly exudate wounds, special cavities, low adherence version of available for patients with fragile skin. It is contraindicated, or some precaution don't use in dry necrotic wounds or those with minimal exudates. Also, we have many studies about that result indicates that highly hydrophilic polyurethane foam dressing may provide an effective treatment strategy for diabetic foot ulcers. Next group, we have hydrocolloids, absorb fluid to promote autolytical debridement. It is indicated in clean, low to moderate exudate wounds. Combined presentation with silver also have a very important antimicrobial activity. As a precaution, don't use it on dry or necrotic wound or highly exudate wounds. May encourage overgranulation. We have to pay attention for this point, as this overgranulation may produce highly moisture wounds and may cause maceration to the border of the wounds. As hydrocolloids, we have no research evidence suggests that any type of hydrocolloid wound dressing is more effective with other dressing in diabetic foot ulcer at least. We have a low adherent wound contract layer, most common commercially or publicly as silicone wound dressing, protecting new tissue growth, atraumatic to peri-wound skin, and conformable to body counters. Indication, low to high exudate wounds, use as a contact layer on superficial low exudating wounds. As a precaution, may dry out if left to place for too many days, and we have some type of sensibility. Also, I can add that silicone in hot country may increase the temperature of the skin and may may produce some thermic lesion, especially in people with diabetes. Is a diabetic foot ulcer pilot study. Does silicone held sheeting reduce the incidence of the ulceration? As a result, does not seem to reduce the risk of re-ulceration, because many people use silicone insoles as a prevention of re-ulceration. And this study demonstrates that there is no way as a prevention. Next one is a PHMB, is antimicrobial action. It is indicated in low to high exudate wounds, critically colonized wounds or clinical signs of important infection may require secondary dressing. As a precaution, don't use in the dry or necrotic wounds, and if there is some sensitivity to these products. We have many studies about PHMBs, as you can see, the action and the function of this important wound dressing. And as a summary, is effective as antimicrobial agent. And if we use it with a broad spectrum of antimicrobial and low toxicity. So the next one, we have a platelet-rich plasma for diabetic foot ulcer. It has been used in recent years with a very, very important results. And the topical application of platelet-rich plasma for diabetic foot ulcer result in statistically superior healing rates and lower complication rates compared to any other control. Other study demonstrates the same. And we have a function of collagen with or without calcium alginate. There's a structural support of collagen with gel forming properties of alginase, maintains a moist wound environment and create ideal condition for healing. It is adherent, flexible, and conformable, sterile, and soft. Also, we have many studies supporting the use of collagen dressing in diabetic foot ulcers. We have dextranomer hydrophilic granules contain microspheres in dry form composed of the dextranomer hydrophilic polysaccharide. When the granules come into contact with the fluid, they absorb water and they swell until saturated. When placed in secreting ulcers, the granules absorb, exudate, and subsequent swelling and formatting of a gel-like mass have been found to be an efficient method of reducing exudate and removing debris from cutaneous ulcer. Also, we have activated charcoal dressing, absorb exudate and bacteria from ulcer bed onto the dressing material, acts as a barrier and absorb and filters the malodorous chemical which evaporate and are released from the ulcer. Some dressing combine activated charcoal and silver at 0.15%, and so this combination will be perfect for odor control and infection control. So if we classify diabetic foot ulcer as a fluid production, low to moderate, and high, we can choose which type of wound dressing is more effective for low, for moderate, and for high production. Angiogenesis, always we talk about that. I think there is not enough time to talk it. It is negative pressure wound therapy. The negative pressure was first used for open abdomen with high intra-abdominal pressure. Later, they discovered the importance of this technique to close diabetic foot ulcer, especially if there is no arterial compromise. We have many studies supporting that. And finally, we have a lot of studies that demonstrate that there is no superior effect or selectivity of wound dressing about diabetic foot ulcer healing in general. It's so important that for each type of wound, each type of ulcer, we have specific type of wound dressing that may be more effective for this type of dressing. Finally, question to ask when considering advanced or a new treatment. Are there other treatable reasons the ulcer is not healing, especially if we have infection, importance of vascular arterial supply, some patient factors, and the most important, I think, pressure relief. Would additional consultant be appropriate? Always we say yes, as diabetic foot ulcer treatment is not only one specialty, it's not one person, it is a multidisciplinary team. And the last question, is there adequate evidence-based medicine that the treatment or product is effective, particularly for the situation of this patient? So as we classify by the colonization and infection, you can see not all diabetic foot ulcer need antimicrobial indication or antibiotics, but if we have some criteria for infection, it is necessary the use of antibiotics. So we have many ways to choose the type of dressing related the quality of the wound, the quality of the patient, quality of vascular irrigation. And the last one we classify the wound in necrotic, sloughy, exudate, granulating, and epithelializing. And in each type of this type of wound, we have a lot of options of wound dressing to be chosen. So as a final message, diabetic foot ulcer treatment, it is not unique. It's not only one pattern. We have many ways. We should see the patient as a complete patient, not only as an ulcer. We should know exactly what is the cause of the ulcer, what are the components of this ulcer. So according to all these criteria, we can choose which type of dressing. Thank you very much. This is my email for any question in the future. Thank you, and thank you all for diabetes in India. And I think not in India, in all the world, we have to look to diabetes in India and to do the same, because you have a very, very important role in education for both physician and patient. Thank you very much.